Hi, good afternoon, everyone. My name is Emily Castillo, and I'm the Director of Programs for Insure the Uninsured Project, or as we are more commonly known, ITEP. We are excited to be partnering with Connecting for Better Health on today's data sharing workshop to support people experiencing homelessness in LA County. For those of you who are not familiar with ITEP, we are a 26-year-old health policy nonprofit and convener with a mission to promote innovative and workable policy solutions that expand healthcare access and improve the health of all Californians. We implement our mission through policy-focused research and broad-based stakeholder engagement. We have three key policy focus areas: coverage and access, in keeping with our original goal of ensuring the uninsured, delivery system transformation, and the future of health and the health system. Over the last 2 years, ITEP has convened regional listening sessions across the state on CalAIM implementation, specifically focusing on building partnerships between community-based organizations and the healthcare delivery system to make the goals of CalAIM meaningful for Californian communities. The CalAIM initiative is a major step towards creating a healthcare delivery system that centers the needs of California communities served by the Medi-Cal program, and implementation is moving forward quickly throughout the state. In these convenings, as we discussed actionable ways to address challenges and build successful partnerships to ensure the success of CalAIM goals, we heard overwhelmingly that a key barrier to addressing social determinants of health is hindered by providers' ability to exchange information between and across various health and social systems. The collection and integration of patient data across sectors in both clinical and non-clinical settings is vital to achieving interoperability between various health and social systems to address the unmet needs of Californians. As we embark on ambitious statewide initiatives like CalAIM and the creation of its data exchange frameworks, which you will hear more about later on in the program, it will be imperative that these initiatives address data collection and sharing challenges and barriers. In doing so, we believe that we will be one step further down the path of creating a person-centered, equitable healthcare system. With that, I'd like to pass the mic to my colleague, Timmy Leslie, founder of Blue Path Health. She has worked for more than 20 years with healthcare policy organizations, IT providers, and consulting firms, and offers a unique combination of expertise in both national and California healthcare policy and regulation. Thank you so much for partnering with ITEP in this work and for bringing us all together today. Timmy?
Thank you so much, Emily. And we have really enjoyed our partnership with ITEP over the course of the last few years. And wouldn't be here without you and all of your support and your team. So thank you again. Hi, everyone. I'm Timmy Leslie. I am with Blue Path Health and here today wearing the hat of Connecting for Better Health, a project that we support and have supported over the last 2 years. In fact, we're embarking on our 3rd year in January of 2023. Connecting for Better Health, we started it as a coalition of stakeholders to be able to come together and support a vision of interoperability in the state. And this started, as I said, 2 years ago, as the governor and several legislative leaders, our policy leaders, signaled that there was a definite desire to be able to make and fulfill that vision of statewide interoperability. And what started as some key policy aims turned out to be, or manifested itself into a past legislation, which was AB 133, and it mandates that for data sharing across the board with several healthcare organizations. And I think as stakeholders, we're really looking to each other to not only work and support each other, but then also support the state in its guidance and its leadership on how to be able to make it real. How do we implement it on the ground? And how do we think about interoperability and data sharing that supports so many needs? Especially if you go to the second slide or the next slide. As we look at I'm going to first give you the agenda for today's workshop before I jump into the work of the data sharing framework and the data sharing agreement. So we're going to go through these welcomes and introductions, and then I will give you this brief overview to be able to set the stage for the day. And then we're going to go through some lightning round presentations, again, to set the stage. How is it working on the ground to support such an important use case of persons or people experiencing homelessness? And then we will move into a facilitated discussion. And although I think we'd all love to be together in the room, rolling up our sleeves with whiteboards and calling it a in-person workshop, we're doing our best to make it virtual and be able to have engaged conversation. So as much as we can, we will be using that QA functionality, the chat functionality, and leaning again on each other to be able to capture those bright ideas and help prioritize them and think about where and how we're going to pursue next steps. Our lightning rounds are about 20 minutes or so, and we have a good hour of good workshopping. So please, stay with us and lean in. So if we can go to the next slide, I want to thank our sponsors, the Blue Shield of California, and the work that we've been doing with Blue Shield of California in their industry initiatives group, who are on today as well. Thank you so much for, again, your vision of being able to bring together your competitors at some point, and sometimes, as we all are in healthcare, all about supporting the patient and supporting providers. Thank you for your leadership in bringing us together today. And also Cedars-Sinai, who, probably about 3 years ago, raised their hand to say, what is the data sharing landscape in LA County? And it was their very formative work where I think so many conversations started and where you all have been able to move that conversation along. So again, thank you for Cedars-Sinai, and thank you to you both for supporting the work of getting us all here today and the work that will come after today's session. And if we go to the next slide, so this is where where we're really kind of looking at where is the meat of pulling us into a data sharing framework, is what the state is calling it. And this was passed through the legislation, as I said, with AB 133. And it really starts with a vision of every Californian will be able to have an access, and their providers be able to access health and human service information to be able to support their healthcare journey. And I think it's really important for us to be able to ground ourselves in that conversation, because when we look into the details of the data sharing agreement, those organizations that are called out as mandatory signatories are not those that are near many of you that are going to be presenting today, who are working with individuals on a daily basis, trying to meet their needs. Yet, when you look at the data sharing agreement and the data share framework principles, it's grounded in health equity and grounded in meeting whole person care. And as you see on the left, it really looks at not only putting the patient and the provider, as I said earlier, in the center, but all of these organizations coming together to have a shared view of how to support both that provider and that patient. And I think when you look at this, there are so many of these entities that are called out, organizations that are called out, that are not necessarily on the required data sharing framework or data sharing agreement, that really gave us pause. And as an organization that works towards helping with educating and helping with getting the same vocabulary and helping for all of us to get on the same page, we came together with ITEP to say we need to be able to have this conversation and use one or two very significant use cases or primary use cases to drive what may be the gaps in the framework and also the data sharing agreement that's there today in order to meet this vision. So that's really what started all of this work. So if we go to the next slide, here's the data sharing agreement. And this is at a really high level. And my colleagues, I believe, will be putting in the chat links for you to be able to learn about the data sharing agreement in its entirety and in its detail. But for the most part, just think of it as a very high level agreement that will require organizations to exchange health and social services information, not only when requested or upon a query, but also when there's known information that it should be pushed to organizations to be able to better the care of that patient. It also will, and hopefully, get down into that granular know-how and what data will be sent and what standards, and hopefully we'll be leaning on and using those national standards to be able to do so. But of course, it also needs to be secure. We need to make sure that we have the necessary regulatory requirements and making sure that data is not only secure, but private as well. So, and just one last piece too, is that it's also there to be able to capture that ability for the patient to access it individually too. So individual access is there. So it's a lot for us to be able to really undertake and then make sure that we can implement it on the ground. And then if we go to the next slide. So the state has convened a advisory group as well as what they called the data sharing framework group or advisory group. And over the course of the last year, we are now in that next phase where we have a data sharing agreement, but it needs to be moved into implementation. So that phase is just kicking off. And we really anticipate that these big, as I call it, the big rocks of big leaps need to be made into making sure that we all understand the more of the details in each of these big areas. So how will governance be done at the state level and also at the county, region, local level? What kind of enforcement will be engaged as part of governance? Also, as I've been talking about throughout this, level setting is who needs to sign these agreements. And I think it is really important for us to define not only which type of entities or organizations are required to sign, which types of organizations or entities should sign, and at what level of the organization. And when an organization has partnerships or subsidiaries, at what point do these data sharing agreements need to, what is the umbrella that those agreements cover? I think we're all eager to be able to get into those details, and maybe here today we will highlight some of the areas that need to be discussed in detail, and then also codified perhaps, or put into regs so that we can refer to it and know that we can count on each other to be doing some of the similar activities. And then in terms of qualification, as part of the data sharing agreement and a part of the data sharing framework, there's this notion of a qualified health information organization. And as part of Connecting for Better Health, we definitely see that there needs to be entities or organizations that regions rely on in order to make sense of all of this data sharing. And often, at least when we look at in some regions across the state, as well as in other states, these are called qualified health information organizations or qualified health information exchanges. And in some instances, we also hear them referred to as community information exchanges. But we, again, need to come together. What does that mean? How do you get qualified as that type of entity? What role do you play? And how do organizations interface with you? And do you work with one or many? So again, that's an area that we'll be looking forward to having more detail. And then finally, what I said earlier about privacy and security, how are we dealing with what's the identity strategy, especially at the state level, at the regional level, city and county level, and organization level as well, and consent. So lots here, lots to look forward to. Part of what we do as Connecting for Better Health is look at, again, like I said earlier, other regions or other states that can lead the way. And we definitely have examples that we can look at. How do organizations come together to be able to support the patient in a specific region and across regions? And how has that been done? How is it being sustained? And how are these organizations that will be having this discussion today making decisions, and then being able to come back together and look at what works, what doesn't work, and improve. So that's the context that I definitely wanted to set for today, and we are here to answer your questions. Please again use your chat or use the Q&A, and we will address those questions. And if we want to go to the next slide. So I am going to hand it over to the start of our lightning rounds. And at first, I'm going to introduce with you our colleagues at PATH. And they are, let me look where. Glenn Hilton, Glenn, are you there? Hi, Glenn.
Yes, I'm here. Hi.
Also Claudia Garcia. Garcia, do you want to turn? I don't know if there you are. If I could have both of you just give a brief introduction of yourselves and your organization. And I know that you are going to take us through your experience today with data sharing and how you see some of the gaps kind of helping or hindering your work.
Great. Thank you for that, Timmy. Absolutely. So my name is Glenn Hilton. I'm the Director of Community Care for PATH in San Diego. And Claudia, I'll let you introduce yourself before I start the slide.
Hi, everybody. Claudia Garcia. I am an LCSW, currently transitioning into the Health Programs Director role at PATH as we expand our programming with managed care plans in LA.
Thank you. And so for those of you who are familiar with PATH, you'll know that we are not a traditional healthcare organization. We are a nonprofit CBO that is dedicated to ending homelessness for individuals, families, and communities throughout California. And we do this by providing a full range of services, by building affordable housing and providing supportive services throughout California. That includes everything from outreach to housing to providing healthcare navigation for individuals experiencing homelessness. We're currently operating in over 150 cities in California with 60 actual physical locations within those regions. And all of the regions are listed at the bottom there. We're presenting specifically regarding Los Angeles, Orange County, and San Diego today because those, particularly Los Angeles and San Diego, were kind of thrust into the Medi-Cal world. We dipped our toe in the water a little bit with Health Homes work that we were doing prior to 2022, and then charged full steam ahead into CalAIM. And with the advent of access to people experiencing homelessness to an open referral source, CalAIM's been a really wonderful resource, but of course, there are challenges in any new transition. So I'm going to start by letting Claudia talk through a little bit about some of what she's seen in Los Angeles and Orange County, and then I'll pick up and talk a little bit more about our experience here in San Diego.
Thanks, Glenn. Hi, everybody. Again, happy to be here and share a little bit about my experience in LA. So I think for a long time, we've known that homelessness and healthcare are directly correlated. In LA County, we've been working with the Department of Health Services, also known as DHS, using that philosophy as a guide, specifically with contracts and intensive case management services, which includes scattered site tenant based subsidies and also project-based subsidies, re-entry ICMS, which involves our justice-involved population, street-based engagement out of the Harbor UCLA Hospital in Torrance. And in 2018, we also began to dive into the managed care plan world via Health Homes, and that led us directly into CalAIM, as Glenn shared. And so in LA, we currently work with 2 managed care plans. We are contracted to do both ECM, enhanced care management, and community supports. With community supports, we do housing transition, housing tenancy, and housing deposits, which really is in line with a lot of the work that we're already doing. So it just really made sense for us to dive into that world as well. We currently have about 60 participants and hope to grow as more healthcare plans come online and as we just grow as an agency in CalAIM in LA. And I did just want to point out, as Glenn mentioned, we did just start CalAIM in Orange County as of 10/1. So we're super new, super baby steps, but we are really excited to grow that as well. And there, as of now, we will only be doing community supports. So we can go on to the next slide. Thank you. So our experiences in these programs have given us an understanding of the landscape and the challenges that make up social services in LA County. We are super grateful to know that, all these agencies are working really hard to change the way MCPs and community-based organizations work together for the greater good of social services. And I think in our current experience, it has to be said that COVID has completely changed the way we interface with healthcare all around. Even at work, we rely so much on technology and virtual experiences to meet. I mean, we're all meeting here on Zoom now. And so, I'm applying that same concept to the people that we're providing services to. And it doesn't take long to understand how much harder it would be for someone to get that same kind of help and care, right? So I can, take my phone and go on my Kaiser app and look at my blood test results or get a reminder for when my next appointment is. And we just know that that's not the reality for the people that we are providing services to. So it really is up to us to step up to that plate and help people become more connected to care, and obviously to housing, and just kind of like a wraparound care. And so in terms of data frameworks currently in LA for CalAIM, we use HMIS and portals managed by managed care plans. For internal documentation, we use something called Vertical Change, which allows us to keep digital files, which is really great because we all know how paper files are a little bit hard to manage. And then in my previous life working with DHS, we also use something called CHAMP, which I like to think of as a kind of like a baby one-stop shop in LA County. And I think as service providers, having to use multiple platforms can sometimes be tedious. And in our work with multiple managed care plans, we've seen how sometimes requirements can vary. So we started thinking, wouldn't it be great if there was like one portal where we could access information and really wrap care around a person? And we've since heard about the data exchange framework and all the wonderful things that are happening. So we're just really excited to tackle the challenges that we're seeing together. Next slide, please. Thank you. And I don't know that I'll go through all of these because we have, we'll be talking and further down the line, but I do want to point out a couple of these challenges and recommendations now. Specifically, obtaining information far too late. So regarding hospitalizations, I think that's a big one for us. We tend to hear about hospitalizations once a person is no longer at the hospital. But what would it look like for the healthcare provider to be able to say, hey, this person is connected to PATH, they're connected to both ECM and community supports, right? That they have a care team, and maybe we just haven't been able to find that person, or maybe that person got lost. So being able to see that information in real time would really enhance the service provision. And then moving down along to an ability to find participants who are likely connected to a provider we could easily call. Sometimes people are super well connected. We've seen that people are really well connected to healthcare, to their PCP, which is great. But that doesn't mean that we can find them because we don't know that, right? So maybe that information isn't listed on CHAMP or on any of the other portals we're using. So really being able to have access to that in one place would be really helpful as we just move along in the CalAIM world. And so for recommendations, the first one, including housing as a component so people can be better linked to available housing resources in their counties. With the thought that managed care plans will begin to fund housing units and or subsidies, a portal that tells providers that someone is in line for it or even allows members to queue up for it would be a game changer. I think we all know that every county deals with housing in different ways because housing looks different in each county. In LA, we of course struggle a lot with housing even being available, but I think that many times someone does not even have the opportunity to get on some sort of queue for it because there really isn't like a access point. And then for the last two, I can combine them. Housing authorities and county benefit providers. I think we've all seen people that fall through the MIA cracks when, maybe someone was at their last expiration for their voucher, or maybe they needed one document to submit to DPSS and that didn't happen, right? So if these agencies can also come to the table, it would really help us better connect people to care and people not lose access to funding or even access to their housing. And I think that's the last one before I send it over to Glenn.
Thank you, Claudia. And just to clarify, the reason that we decided to present the two Los Angeles and San Diego experiences separately is we did implement these programs in parallel and in collaboration, but we did take different approaches. And so some of the experiences were fairly different. In San Diego, we were both a health homes and whole person care provider. So we did have a ready pool of clients when we started with CalAIM at the beginning of the year. So we very quickly had to ramp up, which was challenging with some of the interface issues that we encountered, which I'll talk about in a few minutes. When we first started with CalAIM, we were an enhanced care management provider. However, as of September 30th, we discontinued ECM services, and that was for a variety of reasons, some of them being technical and some of them being budget related. We do continue, however, to be a community supports provider, providing the housing suite, if you will, the transition navigation services and tenancy services for ongoing supports post-housing, as well as assisting individuals with housing deposits. And in our shelter, we provide recuperative care and short-term post-hospitalization housing. So all of those are different types of services, different types of benefits with different billing models. And a lot of data is needed to be able to handle that. Also, we did contract out of the gate with 6 managed care plans out of the 7 that we're currently operating in San Diego. So you'll see there were a lot of differences there as well. In 2022, we've had over 200 clients so far. We're currently at an enrollment of just over 100 as a result of no longer providing ECM and having graduated some of our clients. We can go ahead and move to the next slide, please. Thank you. So I thought what would help here is just to kind of give some challenges that we've experienced, some of the workarounds that we've had to use in order to get through them, and then time permitting to be able to also speak a little bit to some recommendations. And so in terms of challenges, the biggest thing that we've really noticed, similar to what Claudia said, is just that the data is really fragmented. We have some information in individual managed care plans, care management systems, some in HMIS, some in CIE, and some in HIE. So trying to consolidate that information and use it on a daily basis in a efficient way is really challenging, and causes us to kind of have to scramble to move data from place to place. Within the 6 plans that we used, each health plan had different data entry methods, data access availability, and referral and authorization pathways, leading us to really have to silo our care teams by health plan when we were operating under ECM, because trying to train a workforce to be able to operate with 6 different modalities would have been very challenging. We were also surprised to find that the data entry methods and data access were different within a health plan, oftentimes, depending on whether we were dealing with enhanced care management or community supports. And that the information available for community supports providers was severely limited compared to that for ECM providers. In fact, we had a system we were required to use when we were an enhanced care management provider for some clients. And then as soon as we were no longer an enhanced care management provider, we no longer had access to that information anymore because we were only a community supports provider. And that can cause real challenges when we're trying to enroll new community supports clients. The clients make contact with us, we begin a relationship with them, we submit an authorization, and ultimately may find that in fact they were not, that they're already enrolled with another organization but don't know it, or that they are enrolled in another organization and have simply lost touch with them. And so it makes it difficult. We've already invested in a relationship and are then not able to serve them. We also found a real challenge in being able, once we had to input information into healthcare plans, EHR systems, their care management systems, that often retrieving any of that information for outcome reporting or performance management or to submit claims was very difficult. We generally could not extract reports on our own. We generally had to make requests of the health plans, and in some cases they were able to meet our needs, and in other cases they weren't. outcome reporting is really important in homelessness services. It's the only way we can really start to benchmark the progress that we're trying to make. And so having all of our client data in one system that we can't extract from wouldn't be feasible. We also found a disconnect in some health plans between case management data and the claims billing data. We would input information into their care management systems, and then they would direct pay the claims and they wouldn't match up, or we would have to actually re-enter the information in a second system in order to get the claims paid. Ran in sometimes to an absence of known referral pathways. So our hospital providers and some of our larger healthcare providers in the community have expressed concerns about that, not even knowing how to get people into recuperative care, for example, or what organizations are providing community support services. And so we're believing that there's a need for some real data syncing in the community, not just within the direct provider. Also, I've already mentioned the next one, and then the claims payment also is contingent on re-verification of enrollment status on a monthly basis, which, of course, if you've got a large population that you're trying to serve, having to do that again every month on a manual basis, which is often the means that we have available, can be really challenging. So some of the workarounds that we had used in order to get past some of those challenges, the first one is just duplicate data entry. We had to maintain a separate EHR system internally, and often we're entering the same information in that system as well as in the managed care plans care management system. We were not successful at finding the ability to export data or import data between those two systems, and some reluctance for data privacy reasons on the part of some of the health plans to do that. We also ended up having to kind of merge data from multiple systems from different data formats, which made it kind of challenging to get consistent data. We were also have created some collaborations within San Diego County between providers and with our 211 CIE organization to try to really help solve some of the gaps about knowledge sharing in the community, sharing bed availability between providers, which we're kind of having to do outside of the normal healthcare system because it's just not readily available within it. And the final thing is our associate director and program manager have literally in some cases had to just go person by person to do record review to make sure that our staff is in compliance with all of the expectations of the health plans. And that's something that we'd like to be able to obviously do in a more automated and efficient manner. I imagine we'll get to some of the proposed solutions during our roundtable conversation in a few minutes. I'll hit on one or two that I would say are really crucial that I don't want to miss out on speaking to. I do think the need for universal access to basic healthcare enrollment information and social determinants of health indicators are really important for all Medi-Cal providers, and that includes those that are providing housing services. They are doing work. They're part of an integrated team with the enhanced care managers often, but don't have visibility of the information that can help them do their jobs. And then I know Claudia already mentioned the need for a one-stop shop. And then the other thing I'd say that's really critical is just automatic notification to providers whenever Medi-Cal enrollment ends or their eligibility for a particular service ends. We've had people change health plans and we may not find out about it until claims are getting rejected a month and a half later. And by which time we've invested a lot of services that won't be compensated. So anything that we can do to streamline that notification process would be really, really beneficial. I think for now, I'll pause it there and turn it back over to Timmy.
Yeah, we can't wait for us to kind of dig into some of this, but just there's almost some easy fixes you think, and I hate to use that term, but some quick fixes maybe that I know aren't as quick as we think, but something that we can prioritize in a quadrant and go tackle. And then there's those bigger ones as well. But thank you for laying this out for us. And I think we'll hopefully be able to kind of see a theme as we move forward. There were just a couple of questions, and I think instead of moving, once we have all of our panelists on, if I could just have you each addressed at the few of the questions that came in. Glenn, there was several around your desire or your decision to move away from ECM. I think some of the participants, our audience is looking at what was that decision making and some thoughts behind that.
Sure. I think the quickest and easiest way to say it without taking a lot of time is that it was really twofold. The demands on ECM providers are pretty strict and pretty specific. And the staffing model that we felt we needed in order to provide that level of support was not funded adequately with the fees that we were able to negotiate. We were trying to keep an eye out for IPP or cited funding, but unfortunately they came so late that we kind of had to make decisions before we got to the point of finding out what would be funded through them. So I would say that that's the primary driver, was really, and that not being a healthcare provider, we often don't have a lot of the health related information at our fingertips that is expected of an ECM provider. And so we were having to invest a lot of time to get that information from providers, et cetera.
Thank you for that. And I think for Claudia, you mentioned, and I think that was before Glenn, you mentioning over 200 participants, but Claudia having 60 participants. Just to be able to describe the effort that you are going through with that sign up and what it's going to take to be able to grow that network.
That's a great question. So many of our 60 members were grandfathered in, thankfully, from health homes. But to build up our ECM caseload, it can be a little hard at times, specifically because sometimes it's hard to find people. So I think, we go back to the idea of having more access to other portals that can give us more information about the previous care that people have received and where we can find them, or what other agencies or PCPs they might have been connected to.
Terrific, thank you. And I'm going to move us on to our second presenter, and this is Downtown Women's Center. And we have Rosario Trejo, who's a Senior Director of Housing, and Michelle Shireen, who's the Senior Clinical Social Worker. And both of you, I believe, are going to tag team on this. And thank you for joining us today.
Yes, thank you. Just waiting for Rosario to come on, but I could get us started. Yeah, if we can, again, I'm Michelle Shreem, Senior Clinical Social Worker. So I have been trying to kind of incorporate CalAIM into our program into one of our programs at DWC. Just a brief overview, we are a community-based organization. We are in Skid Row, and we specialize in serving and empowering individuals who identify as women and have histories of homelessness and oftentimes trauma. We offer a lot of different kinds of housing-based services, also mental health services and case management services. This also includes our own permanent supportive housing units at our San Pedro site and LA Street site as well, with participants living on site and receiving case management support. Oh, sorry, you're muted, Rosario.
Sorry. Okay. Hi, everyone. Nice to see you all here. My name is Rosario Trejo, as I was introduced, and I oversee our field-based and site-based services across our housing programs. Like Michelle mentioned, some of these that are scattered site are tenant-based tenant-based vouchers for subsidy services. And we do own and operate 119 units across our 2 sites on Skid Row. So just a little bit of an overview of the current services that we are providing our participants. And we currently capture data across some platforms that you heard mentioned previously. We use LASA's portal on Clarity for documentation, as well as a DHS platform on CHAMP. And we use these platforms to support our outreach efforts, to document those efforts, sometimes even to locate folks, and we have access through those portals to someone's history of homelessness and accessing other housing services, which is beneficial and also sometimes a challenge because we only have access to that information on those portals if someone has accessed services elsewhere. And I'm sure we'll dive in more to this in the discussion part a bit later on, but we also had very similar experiences and challenges, as well as observations, as Pat mentioned right before.
Wonderful. Well, thank you for getting started. And it seems like we definitely have some themes brewing here. So I'm going to go ahead and introduce the rest of our panelists. And I just see there's a few, just before I go for very specific questions. There's one question, I think this might be back to the PATH folks and or Rosario or Michelle, you might be able to address this too, but there's a question around the reasons that claims or authorizations are often denied. I heard that missing information or eligibility, but do you want to just give some context around that for those listening in? Rosario, do you want to take that?
Sure. Yes, we have experienced claims being denied if there's information missing on the referral, and it can be sometimes as simple as a box was not checked, and that may lead to a denial or really anything but an approval. And I think, as Glenn mentioned, we run the risk of then providing services for a period of time that we won't, get compensated for unless that is approved, and we have a very clear understanding that that claim has, or that referral has been denied.
If I could also add to that, just from our end, we do not have as many clients as PATH, but we do have similar situations come up where from the time someone has been referred to us for CalAIM services, specifically community supports, which is what we're focusing on, it is possible that a denial comes up when we put in, some sort of billing or claim because that person has been connected to another provider for housing services, specifically housing navigation and tenancy services, which is what we focus on. So similar to what Glenn was saying, as far as being able to more easily see if someone's connected, if they've been linked to another provider, so that we don't get caught in that situation of providing duplicative services, which is a big no-no here.
Of course. And I'll open it up for Claudia or Glenn if you want to add there.
Hi, yes. Early in CalAIM, I would say we were getting a lot more denied claims, and some of it was because, or denied authorizations even, because they were actually expecting clinicals for just, basic community supports for housing, which was not a requirement of CalAIM, but some of the health plans were interpreting that was needed in order to get the authorization, because more than anything, I would say, because that's their history, and it's what they were familiar with. So there was a lot of cross education, I would say, between the care plans and the providers early in CalAIM, and I'd say that we've come to understand each other a lot better. So those claim denials have gone down for those reasons. There are other claims, though. We've gotten claim denials because of duplicate entries in a day and things like that, which, if it's a per member per month fee, that's not a problem. But if it's a fee for service, that could be a significant issue, because multiple meetings in a day is not at all unheard of when you're working with people experiencing homelessness.
Great. Thank you for that additional context. I really appreciate it. I am going to again welcome the rest of our panelists up. We've got quite the crew here that can bring together this wealth of knowledge around this single, what we call in the technical world, use case. And one thing that we've talked about in having to kind of make real this data sharing framework and data sharing agreement that the state is sponsoring is how can we put it against a very discrete use case. And of course, today we're talking about persons or people experiencing homelessness in LA County, because if you move from different regions, we tend to have a different conversation. So we needed to start somewhere. So I thank all of you for joining us today. And as I think we've got some popcorned conversation or questions to you, when I call on you and introduce you, if you could also just give a brief overview of your role in your organization, I think that would be really fantastic. And I'm going to start right now with Allison and Matt. Allison Kerfield, who represents Kerfield Consulting, but you work with LA Care quite a bit. We all know you, or everyone else here knows you, working shoulder to shoulder with you in LA. So I would love for you to be able to start out our conversation. And then also with Matt Moyer from CCLAC, or Community Clinic Association of LA County, one of our partners we work with quite a bit. If you could also join in here. But I think if we could start off with CalAIM. It sounds like we've got some muscle building with CalAIM. What have you seen? What have we learned around the requirements of CalAIM, the phases of CalAIM, and how we can solve some of these data sharing issues using that kind of very, very discrete CalAIM use case, if you will. So Allison, I'll hand it to you first.
Sure. So hi, yes. I think CalAIM is kind of a big piece. Specifically, we're talking about only 2 programs in the big CalAIM umbrella, right? CalAIM is a kitchen sink. We're talking about, like just the corner that's got the scrubby brush in it. So I think in terms of what we might look at, I just kind of want to draw out that beyond the relationships between homeless services providers and health plans that are becoming newly kind of engaged through ECM and CS contracts, we also just have to be aware of what is the architecture of homeless service and healthcare data sharing in LA that sits on. So I'll just point out that in LA County, we have 4 continuums of care. 3 of them, LASA, the real biggie, Glendale and Pasadena, share one HMIS, or Homeless Management Information System, with Clarity. Long Beach is a separate COC and also has a separate Clarity contract. We're working with the COCs as part of our HIP Housing and Homelessness Incentive Program to fund a future integration. So that might be something coming online in next year or the year after. But even for homeless services providers, if you work down in Spa 8 in Long Beach, you're already entering just in your homeless services contracts into 2 different systems. And outreach, people walk across the city lines all the time. So that's one piece of it. I think one thing that we've kind of been asking is, there are only so many HMIS vendors statewide, right? Like a lot of people use Clarity, a lot of people use Client Track. There aren't that many. And while we need to really focus on the specificity of what do we need here in LA, we also might be able, especially with the statewide leadership, to think about, are there integrations that could start to become standard APIs between health information exchanges and HMIS systems, for example, that could help kind of solve all of our problems. So like, for example, in HIP, there's a metric where health plans and continuums of care are going to start in 2023 sharing data, matching data. And some of the things we're going to start sharing from the COC to managed care plans will be things like housing placements, CES points of contact, which are kind of the service providers working with somebody in the homeless service system, interim housing placements, permanent housing placements, all that's really great. And then what can the plans share back? ECM and CS enrollment is really big because there's actually no countywide system that sits in right now. You have to ask every plan, which is really an issue we heard from PATH and DWC is, okay, who's got eyes on this client? We're going to start sharing initially quarterly, then monthly. It's going to take probably all of next year to get it into a good shape where providers really start seeing it in HMIS, but that's one thing. But also even just what health plan is this client with? What plan partner, if the person's with a plan partner, and what primary care provider are they with? So that really basic information that any healthcare provider can look up one by one in the AID system is something we want to add to HMIS. But I wonder if we could think about that with the data sharing framework. Is that something that could be standardized? If we figure that out, I think we're going to want to know it's not even the healthcare information, but just the service information in terms of healthcare services and programs. So that's some of the thoughts on where we might start. I think the big thing is that, right now with CalAIM, plans and providers are building all this infrastructure one by one because they just need something.
Yeah.
But we don't really have a commons. It's unfortunate.
And I'm always reminded and I think we all know this, but how large LA County is, especially for some of us that reside in the Northern California area. So it's, it's by block at times, I'm sure, of who might have a viewpoint over this individual. So I'm going to move to Matt. Matt, as a provider, what are you seeing in your experience with CalAIM on a starting place?
Yeah, thank you. Matt Moyer here. I'm the Director of Clinical Services with the Community Clinic Association, and our organization represents 65 federally qualified health center organizations all over LA County. So to put the largeness in perspective, we're one of the largest associations, and they, of course, represent well over 300 clinical sites all over LA County. A pretty big handful of our members were health homes and transitioned into CalAIM at the start of the year. So we have a number of our organizations that are through this implementation or starting this process. But I agree with kind of what the other presenters have mentioned up to this point around really the data sharing challenges. And we, of course, work closely with LA Care and HealthNet because we have a number of our organizations that really need to align with what both of the managed care plans are requesting for implementation. But I think especially when clinics need to collect, we call them social drivers of health, social determinants of health. It's really we really want the community clinics to be able to collect this data in a uniform fashion. But what we hear is they're really struggling, and I kind of beat a dead horse here, but the clinics are really struggling currently with workforce issues, because when we talk about all of these different social drivers of health, homelessness being one of them that has to be collected, they don't always necessarily have the workforce behind it to really be able to tackle all of the data collection and then transmission requirements. So, the workforce is definitely a big piece. And then as we look at different social drivers of health, some of our clinics have memorandums of understanding with different community-based organizations, Downtown Women's Center being one of them. So I think really being able to have those agreements in place, it allows them to really be able to start to really collect and share data a bit more. I would just say when we look at trying to track where a patient is in the system, when we look at social drivers of health, it could be really challenging because there's not necessarily a closed loop referral. So when a provider is going in and being, okay, I see this patient was at the emergency room, but did anything occur after that? And really being able to close that loop has been something that I think our clinics have been challenged with in the means of really tracking the patient.
Thank you, Matt. I mean, we see that over and over, not in just in, of course, homelessness, but in many of the use cases where individuals are referred, and yet there's no insight as to whether or not that individual made it to the specialist, that the student was able to speak to the behavioral health specialist in a timely manner, and then be able to get that back. So it's, I guess that just is another layer of what we're talking about is that closed loop. Well, we tend to call it closed loop. Thank you. And I'm going to now move over to Jen. And Jen Behrens, you work with Lanes, which is an HIE in LA County. So if you could give us that overview, as well as what are you seeing? And I know we've heard this kind of idea of a one-stop shop, of a need to be able to have, I guess, a traffic cop in a way, a healthcare traffic cop. I don't know if I've ever used that analogy before, but something like that Lanes could provide that would then not only, I think, cover some of this eligibility work and HMIS, but then also social determinants, and then we just heard closed loop. So, lots of layers.
Sure. I will try to peel that onion
for
us. My name's Jen Behrens. I am engaged as a CISO for Lanes through a privacy and security consulting company called Kuma. Have been the CISO for Lanes, I think since 2017, so a while. One of the things that I have enjoyed and appreciated most about Lanes is their dedication and commitment to serving the safety net population within the LA and the surrounding areas. And through that, Lanes has very much committed to not only providing the more traditional HIE services between providers and healthcare organizations, but also looking at innovative ways to partner with organizations that may be considered non-traditional entities. And so we have consistently looked at ways to do that, including some of those closed loop referrals where it's almost making a little section for organizations to look at how we can accomplish data exchange and sharing. Lanes has been an active participant in the work groups that have spun off of AB 133, both on the main board level committee, if you want to call it that. And specifically, I participated in the data exchange framework subcommittee, looking at policies and procedures to help organizations that are not considered traditional covered entities be able to exchange information in a secure and privacy enhancing way that also facilitates access and treatment and that holistic look and view and treatment and service provision towards patients. And so have been on behalf of Lanes working to really further that. I mentioned Lanes has taken that sort of traditional approach. I'm going to not say traffic cop because that gets the stop, start
Right.
kind of approach. I think we're more of an enabler of exchange between organizations with certain guidelines and guardrails, because it is protective health information. It can be considered sensitive health information that have more guardrails and just more sensitivity that everyone would like to appreciate, that organizations who are exchanging their information should take extra care with this type of information. And we have onboarded the more traditionally thought of covered entities. So your providers, clinics, and healthcare or payers. So your insurance providers. Again, that's a more traditional model of an HIE. We've also additionally started looking at working with community-based organizations and organizations that specialize in the exchange of social determinants of health or social drivers of health, so that we can help support a more holistic view of a person in the community. Before, this is my second career. My first career was a foster care social worker for local government forever. And so I very seriously take to heart a commitment to working with social service organizations and providing services to support people, families, young families, women, children, especially as they are navigating through a lot of different disparate organizations that likely don't talk to each other. That when I was at social services, I used to say, we have all this data, it's dirty, but we have it. I wish we could do something with other organizations. And so that's something that we and the state and the federal government has been trying to establish more standards on interoperability so that how we can meaningfully exchange information so that the information speaks to one another and doesn't fly right past each other if we can figure out the exchange part. And so Lanes has really been on the cutting edge of that, and I'm very excited about that.
And I think you just touched on this, and we heard it earlier, but just a little bit around, the protected health information and how some organizations are protected by HIPAA and some are not. And one of the preparation calls we had, we were all, sometimes HIPAA, and when we say the word HIPAA, people shy away from it, but in fact, maybe we should be embracing it to be able to get us kind of over to that next phase of data sharing. Do you have some thoughts there?
I do. I love HIPAA, so I will talk about HIPAA all day long. What I think is important for people to understand is that HIPAA was actually designed to be an insurance interoperability regulation. It was designed to help organizations exchange information. The security and privacy rule came out of that because we're now having all this data trying to fly back and forth. And so we want to make sure that appropriate safeguards are in place. Between my love of HIPAA and in my role as CISO, my emphasis is making sure that we are protecting people's information in a way that enables services to be provided. HIPAA should never be thought of as a stop block. It should be considered as a way to make sure that we're all protecting information and safeguarding information at a fairly decent level. It was codified in '96, and one of the beautiful aspects of HIPAA is that it really recognized it was 1996. We're not going to nail all of this. We have ideas of what should be standard requirements for organizations when we're looking at securing and safeguarding information, but we recognize that not every organization is going to be able to meet or should have to meet certain sets of these criteria. So in really thinking forward, there are standards that are articulated in the security rule that are required and that are addressable. And so the addressable ones really give the organization a little bit of leeway, and it says how you consider this. It gives you a factor quiz, so to speak, to understand what you should accomplish that are addressable and what you shouldn't. Now, certain things, like in '96, encryption was considered addressable because that technology was expensive and it could slow performance of systems way down. You didn't also have a lot of people who specialized in it or organizations that would sell the product off the shelf. Mm-hmm. In 2022, that's really a standard level security item. And so when I'm looking at assessing risk of inviting new organizations into the Lanes ecosystem, one of the questions I ask is about encryption. And that is a requirement of participating in the Lanes ecosystem. Because as a CISO, safeguarding the protected health information and mental health information and possibly substance use data, I need to be able to say, I am only exchanging with organizations that will encrypt the data. That's not a high bar, that's a reasonable bar. And so the conversation I have with organizations now is how do we get to this floor of HIPAA security? And if you're not there, these are the things to do. And these are the touch points that I'll have with you to see if you can get there and to provide guidance if I can on how you accomplish that. Because what we don't want to do is, one, invite more risk into the ecosystem by having organizations access information that cannot safeguard it or protect it. But we want to make sure that we offer every opportunity to organizations that can get there or that have that to participate, so we can continue expanding and offering services to more and more community-based organizations, providers, healthcare organizations, so we can continue to reach more patients and consumers.
So what I'm hearing, if there's a will, there's a way, and there's a way to do it securely.
Absolutely. Absolutely. Yes.
Well, I'm gonna pull back in our team from the Downtown Women's Center and just be able to, after you've heard this conversation, what are your thoughts on being able to kind of have this kind of one-stop shop, what are your, if it were to be, what would you think of it as, some high priorities, as well as what concerns might you have?
Yeah, I think this is something that Rosario and I, in preparation for this, have talked a lot about, and we even drew in some of our direct staff to get some more information of what's it like right now for for you working directly with clients, inputting notes, inputting assessments, working with vouchers. And you know, it was a really overwhelming yes to data sharing and having this universal platform portal, especially with having CalAIM in the mix now, which is an amazing program and a great shift and direction that we're going into. But it is very complicated at the same time. And it can be very confusing from our personal experience and hearing other providers, maybe in our position. We're working with only 2 managed care providers, and there's so many differences between the two and their requirements, their portals, their platforms for, notes and authorizations, and then claims and billing is a whole nother thing, which is understandable. But this system that we're working in already is so complicated, and housing is already so difficult to navigate, that having this platform or data sharing where we can all communicate with each other, we can see previous assessments, have direct contact to reach out to someone who just talked to a client we are disconnected from last week, and not have to go through a bunch of loops, that would make a huge difference. And especially talking about homelessness, and it's been mentioned here already, people are moving around consistently. A big part of our population, we work with a lot of women in DV situations or have a history of DV. So there's a really increased concern and safety risk when it comes to anyone experiencing homelessness, but especially some people in DV relationships. So we're kind of, I don't like using the word tracking when talking about people, but we kind of need to be able to track people, and outreach is a consistent thing that we're doing. So having one place where we can all interface with each other, that would really simplify things when we really need it, because we're doing really complicated work. And I just want to point out, one of our senior case manager for the CalAIM program, she really put it perfectly, and I want to use her quote. All the confusion and going through different platforms really takes away from the work that we're meant to be doing. We're not meant to be writing notes all the time, and documentation is to protect us and to help track clients, of course, and it's vital and necessary. But the work we're doing is what's the most essential part of this. So if we can simplify it in any way, we'll take it as providers. I don't know if there's anything else you want to add, Rosario.
No, I think you captured that beautifully, Michelle.
Well, and there's actually a question here that came in through the chat from Kern County. And I think that's, just another complication that you have. So I actually have 2 questions. One is, how do you deal with individuals who show up and say that their last place of address, if they had an address, was in Kern County? What do you do then? What's your next step? Michelle, I'll hand that back to you.
I don't think I've dealt with that exactly. Rosario, are you able to speak to that a bit?
Yeah, I think our first step then would be getting them connected to a CES intake or a VA-SPDAT in LA County.
Start over. Yeah.
Yeah. Which, to someone who may have experienced homelessness for any amount of time anywhere else, and going to LA to seek, to maybe with the idea that they're going to have more access to services because we are a larger county, or maybe, you know, more resources are available, that can be really discouraging and disheartening. And I did hear earlier someone mention the gaps in housing transitions and the different stages, right, from when you're housing ready to actually, you know, leasing up. People fall off of that housing path for a number of reasons, and starting all over again can definitely be a challenge to folks, especially if they're having to regather documentation that's possibly already expired or past the like approved window. So there are definitely you know, some very real challenges around that with huge impact.
I'll put the same question to Claudia and Glenn, you know, to think about what happens, I guess, between LA and San Diego probably happens quite a bit too, but when you think about another county that you're not as connected with, what happens there? And, you know, my second question was going to be around that kind of trauma-informed care that you all give, but I can just imagine having to go through everything over again, especially with some of these situations that you're dealing with, is just more trauma that you're inducing into the relationship. But with great empathy, I hear that. But Claudia and Glenn, if you want to take that.
Sure, I can go first. DWC said it perfectly, and you know, for me in my philosophy, it always goes back to the participant and putting them first, being participant centered, being trauma informed. So removing as many barriers as possible to get someone into care, right? It doesn't matter, you know, what it is that we have to go through. You know, do we need to contact someone in Kern County? Like, do they remember that somebody that they spoke to? And I really love hearing, you know, if there's a will, there's a way for a database that could exist like this. I mean, it has a lot to do with client consent and, you know, finding the least amount of data that our agencies would have access to, but to still get the work done, right? And so I think because we're the ones on the ground doing the field work, it really is up to us to advocate for our participants. Because, you know, and that's why these workshops are so important, because we get to talk about why these things need to materialize, right? Or why these things need to happen. And so, you know, for me, I always think, okay, you know, it's just like, what is the best thing that we can do for the person? Nothing else really. I mean, and of course, you know, there's a lot of things that we pay attention to, right? But just that philosophy of helping someone is really important for us at PATH.
Glenn, do you have anything to add to that?
Not a lot. I'll say, you know, it's lovely when we know that somebody is planning to relocate to another county or coming from one, and we're notified. That's not what happens the majority of the time. When that does happen, we are very collaborative and work with each other across county lines. When we don't have that information, the only real opportunity that we have is the managed care plans. They may or may not have that information about who else they were working with. With CalAIM being so fresh, I think it's less likely right now, but I think it will increase and improve.
And I think that, you know, that moves us to one area where you are all have a common thread here, which is working with managed care plans as part of CalAIM. And one, I think, question, I think whoever wants to raise their hand here, is, you know, what could your partners, your health plans do to make your lives better and easier? You know, what do they have control with that you would like to see them do? Anybody want to go first on that one? Matt, I'm going to ask you to respond, and then Jen.
Yeah, the word that immediately comes to mind is just alignment.
Yes.
So I think if there's any way that and we encourage this as well, working directly with LA Care and HealthNet in LA, even though there's even other managed care plans that are subcontracted with, it's just, you know, if we're going to be collecting data and it's going to be the same measurements, if there's ways for both plans to align. And we kind of did that with an assessment tool that they've developed. We had all of us come together and really align it all so that both plans are asking for the same information.
And is that assessment tool something that would be of benefit to some of the folks that are on this call in the CBO world?
Yeah, and I think it's still in draft form, because you know, we've been going through it, and you know, I think that we'll be making a few more changes to it, but I'm sure we could share that out.
And as a follow-up. And Jen, I saw you raise your hand as well.
Yeah, so the lob on that one was join lanes. Like, that was the easy part. But I will say, one of the things, the services that Lanes does offer as the community HIE is patient identity resolution. So especially,
We have a little bit of Jen, I think we lost you. Maybe Robbie, we could tell her on the back end. I think I can mute. Oh, I can't. Hold on, I'm trying to. Okay, I wasn't able to mute her either. So sorry about that, everyone. I'm sure she'll join us in an instant when she is able to dial back in. But I would ask any other participants on the call out to how can MCPs make your life a little bit easier, short term, long term, longer term. I guess that's how we started, right? What is that what's the quick win?
Sure, I can speak a little bit to that. I mean, one of the things that that I would say would be really helpful is when they're rolling out new ideas, just to even be in dialogue before they're rolled out. What we keep seeing, and not just with, one or two providers, but really getting feedback before things are finalized, the design of data systems, especially. And, I want to share some sympathy for the managed care plans. I realize they're dealing with a lot of people with special interests and special needs, and that can be a challenge. But what was rolled out from some health plans at the beginning of the year wasn't doable, wasn't feasible. And the data processes that came with it were really kind of impossible at first. And we really had to do a lot of extra work to work around it. So I'd say just that dialogue would be really, really powerful.
And I think in LA County, for example, there are more than one managed care plan, Medi-Cal managed care plan. But once you start then looking at organizations across counties in Kern and then San Diego, it's really, we're all in this together, right? Thank you. Claudia, did you want to add to that at all?
Sure. Yes, all managed care plans operate differently for sure. And, I think we are 10, almost 11 months in, going along with what Glenn was saying about communication. I think it would be great to be able to have these conversations about also what's working and what the barriers are, and to take it back to, the model, and just try and improve things as we move along, because it is so new that I think that there's still room to really finesse things, but it involves communication and just talking to the people doing the work to see what's working and what's not.
And I think that a big takeaway as we were planning this workshop today is that many organizations are not aware of this initiative at the state level. And how can we get the word out? How can we have, to your point, Claudia and Glenn, a conversation and make sure that there's adequate time and dialogue and getting into those details and the weeds, and is this workable or not? And hopefully this is the start of a longer conversation. And I think that's a role that both ITEP and Connecting for Better Health, it would love to be able to kind of continue that conversation. But it sounds like there's a need for that kind of partnership and coming together. I'm just going to lean on Matt a little bit more around as your experience of working with that one-stop shop. And we'll hopefully get Jen back here, but what is your sense of how far have we gone to be able to work with an HIE that's in the county working with the safety net, and where do we have to go? I think you addressed that a little bit in your opening, but here's a little bit more time to be able to finish some of those thoughts.
Yeah, I would say at this point in time, there's a pretty big handful of our members now that are on lanes. So I really do see lanes or any type of health information exchange in that format really working, because it is kind of that one stop where, again, as a provider, you can look to see where the patient is in their flow, and if they're getting certain treatment or care, that all could be followed. So it really does make sense. The only thing, as we brought up before, in LA, is just really that there's just still a number of vendors that folks use. There's also different technologies. So I think and organizations are using this and having to pay, particular, vendor fees and in charges for that. So with our membership, we have 10 or more electronic health records that are used. So we spend a lot of our time really trying to bring folks together so that we can also bring even the EHR vendors together. So again, that we're aligning as much as possible, and not each vendor having to create and charge the clinics for that setup, but maybe we can all kind of combine it into one, and then each organization kind of work together on that. So I think HIE really could be the answer, but we still have to get folks using the system more and get them together on it and align it.
And I think you bring up a good point, and we heard at the very beginning too, is not only is it you've seen one EHR, you've seen one EHR, and that those EHRs tend to charge you for changes at the instance level, at the organization level, or even at the site level sometimes. And that we also heard that there are more than one HMIS vendor, and that that coordination also needs to happen. And then we're looking at across the state, more than one HIE or clinical information exchange. So when you start breaking it down by participant and provider, I think you all would probably agree, it doesn't matter who that vendor is, as long as you're getting what you need. And then you have as little burden as possible on your employees and your partners to be able to get the information they need. Is that fair?
Yeah, I think so. And I think too, the managed care plans could maybe help facilitate that a bit. I know, just thinking about the homeless population, there's a number of community supports out now and coming our way. And I think many of our clinics have asked, is there a way to give us like a list of who they are? Because in LA, it's just huge. So there could be multiple providers addressing one topic area, but it'd really be great to have a resource of who they are, so that patients can be connected a lot more efficiently.
Well, I'm looking at our time, and I want to have a little bit of time for a key wrap up, but I want one more question that I want to throw out to all of you that I would love for it to be kind of a lightning round of sorts among all of you. So I think about the data agenda, that it needs to go side by side with an affordability agenda. If we're going to drive efficiency and lower costs and make more true access in our healthcare system, we have to care about data, and we have to care about interoperability, and we have to care about all the topics that we talked about today. But in addition, and we started this conversation, that the state has also put a health equity agenda too, to be able to meet the vision of equity in our healthcare system. I tend to think that we need data as well. But what would you all think about when you put a health equity lens on? What are our gaps? What are our needs for data, and what you do? Who am I going to start with? I will start with Glenn. I see you're nodding the most.
I definitely have some ideas about that. So I think one of the things that we've noticed, at least in San Diego, is that the health plans are not collecting data from us on housing outcomes, and specifically for housing related community supports. I don't know how they're ever going to be able to say what because the premise is supposed to be community supports cost less than alternate solutions. So they need to be able to gather that information, I believe, in order to demonstrate that, so that they know what the budget should look like. And that would be my only thing, I think.
And that, so having a dashboard, if you will, a shared dashboard of how to measure success and what those outcomes are, and you all would be ready and willing to contribute. Awesome. Great. Rosario.
Yeah, I agree with Glenn. I think my thoughts were somewhat aligned there. I think that we would also then need to revisit what the service time limitations are around the programs as they currently are being funded. And so if we really are going to get a clear picture of that housing retention post, first couple of months of housing, I think we'll need to rethink that, because we know that housing retention and sustainability doesn't happen overnight. And so I think placing that time restriction has a big impact.
Fantastic. And Michelle, over to you.
Thank you. Yeah, I think I would just agree with what's already been said. Trying to make this more sustainable, because it's, like I said earlier, it's already so complicated. And I think what's already been said, it makes a lot of sense. Nothing specific comes to my mind other than what people have said. If it comes up, I'll mention it.
Well, one of my big takeaways from our conversation earlier was this idea of trauma-informed data sharing. Maybe we could have data sharing at the center of being like trauma-informed care. So that was my big takeaway.
Yeah, and I think a lot of the managed care plans have responded really well in our experience to trying to promote more person-centered and trauma-informed care language, even, shifting from homeless to someone experiencing homelessness. And those are little things that maybe us as CBOs have grown accustomed to, and other people may not have, but just having this universal platform is trauma informed. I can't tell you how many times as a clinician I've dealt with people who get so frustrated having to share their trauma, family history, homeless history over and over and over again. And there is the possibility to do an ROI and reach out to the previous provider, but that's still a hassle, And so then ask people to do, to talk to you about their homeless experience and try to remember all of that. We already know that that's not going to be easy for them to do. So this could really be a game changer. And I think it's something that we'd have to invest in, but it would be a worthwhile investment.
Terrific. Claudia, do you have any words there?
Yeah, my lightning round answer is just removing barriers. Going along with trauma-informed care, removing barriers.
Terrific. Matt?
Yeah, I just think if we could get access to any types of dashboards or tools, even though not everyone's on the same system, but if there are systems in place where we have data to share, I think that would be great, just so that we could collaborate and share that data back and forth.
And Jen, I think you're on your phone. I want to give you time to. There you go. There you go. Jen, are you there?
Am I here?
Yes. Yes. Sorry. We had a bit of technical issues, so sorry about that. Thank you for joining us back. Did you get to
Of course.
Yeah.
Okay, yeah, and I apologize. I'm in Virginia sitting outside my daughter's tutoring. So it takes, this is the internet. Yeah, so I would say, as we look forward to the implementation of what AB 133 was designed to implement, which was data exchange among traditional and non-traditional entities, specifically housing and social services organizations. There are more organizations that can adapt to the framework, the better, to enable organizations of different types and missions to come together to serve unique people individually and provide targeted treatment plans to them.
Terrific. Thank you. Well, I am looking at my time, but I am just so, again, grateful and So happy that we had this conversation together. I want to thank the team. Emily, if you have any closing thoughts, I really want to give a plug for our teams that kind of pulled this great rock star group together, and Robbie Franceschini from my team that spent a lot of time with you all. And like I said earlier, this hopefully is one conversation of many. We will be documenting this conversation day. It is recorded for those of you who have been asking for the recording, and also we will send out the slides. And I'd welcome you to join a Connecting for Better Health meeting. We have them every other week, and we talk about topics just like this. And it's a great place and space to be able to come together and kind of work things out. And then Emily, I want to give it over to you too with closing remarks.
Thank you, Timmy. Yeah, I just wanted to reiterate that the point that you made about this being an ongoing conversation. We are extremely happy to be in this space with you all and to keep moving this issue forward. So thanks again for all your hard work on this.
And we will come up with the findings from today, sharing them all with you. And everybody have a great, I guess, afternoon, start of your week.
Take care. Thank you.
Okay,
Thank
take care.
you.
Bye-bye.